We are live now, doctor.
Good evening, everyone. On behalf of UC and UC Oculoplasty Focus Group, a very warm welcome to all of you today for our fifth and the last episode of Oculoplasty case presentation series ExPresYO, which is actually a mentor-based initiative meant exclusively for residents and fellows interested in oculoplasty. So this is the first of its kind initiative that arose from a casual conversation with Dr. Puneet Jain and I on how every resident and fellow should be guided to present cases at national as well as international level, regardless of their institute or medical college. So this is a unique initiative where the presenter is guided by a mentor, which they choose or we assign, and making it competitive is only a secondary objective. So we have also collaborated with the YoSlides team of YOSI, who share the same vision. So before we kickstart this session, I would request Dr. Prasanna, who's the Joint Secretary of the Young Ophthalmology Society of India, to give a few words of encouragement.
Thank you.
Say your voice is breaking. I think he got disconnected. I think we'll move forwards. And I would now request Dr. Shruti, who's the moderator of this session, to continue this. Yes, sir. Are you
Aishi, am I audible?
there? Yes, you are audible now.
Yeah, thank you, Aishi. I remember you telling how this started as a simple discussion between you and Dr. Puneet, and to see a whole bunch of oculoplasty and oncology surgeons taking it forward. Wishing you all the best for ExPresYO, and nice to see the collaboration between the YoSlides team as well. On behalf of the GC and entire team YOSI, wishing you all the best for the last capsule of this year. All the best, Aishi, Puneet and team. Yeah.
Thank you, sir. I would now request Dr. Shruti, who is currently a consultant in oculoplasty at the Amla Medical College, Kerala. She has done her fellowship in oculoplastics from LV Prasad Eye Institute, Hyderabad, and has won major awards such as the Best Free Paper Award at OPAI, Best Video and Best Case Presentation at YOSICon, the Best Poster Award, and the Best Case Presentation at 2023 and 2024 OPAI. She's also the executive member of the Oculoplastics Association of India and a dear core member of the UC Oculoplasty Focus Group. Over to you, Shruti.
Thank you very much, Ayushi, for the kind intro. Am I audible?
Yes, you're audible.
Yeah, so thank you everyone. So this is supposed to be the last session of the ExPresYO, which is basically the brainchild of Dr. Ayushi, who has conceptualized to encourage structured case presentations to have meaningful and expert, discussion to create a supportive learning environment for young ophthalmologists, irrespective of, where they come from. So everyone gets to interact with oculoplasty experts. We know that during residency, oculoplasty is not very deeply dealt with. So this platform sort of creates more insights into learning of oculoplasty per se. We have had a lot of small capsules, be it lacrimal, eyelid, orbit, thyroid, etc. And this ExPresYO session is supposed to be the last and final. So this is on ocular oncology and ocular surface. I'm very happy to be moderating this session along with my co-moderator, Dr. Juhi, and the coordinator, Dr. Ayushi Agarwal, who was also my co-fellow during my fellowship in the LV Prasad Eye Institute, Hyderabad. She's a former consultant orbit oculoplasty, ocular oncology at the Nandadeep Eye Hospital at Kolhapur. She is a prolific researcher, and she has 40 plus indexed publications and has 80 plus scientific presentations, a number of awards to her credit. She is also an executive committee member of the OPAI as well as YOSI, and is the editor-in-chief of YoSlides. Really happy to be co-moderating the session with my co-fellow Dr. Juhi Daga, who did her fellowship along with me in LV Prasad Eye Institute, Hyderabad. She is currently a consultant in ophthalmic plastic surgery at Vasan's Eye Care, Bangalore. She had completed her residency ophthalm from AIMS, New Delhi, and did her senior residency from PGI Chandigarh. She has won the Best Free Paper Award in APAO 2023 in Malaysia and has won the Best Challenging Case in OPI 2021. So I would like to request Juhi to introduce the expert panel and the judges for today. Over to you, Juhi.
Yeah. Thank you, Shruti, for the kind introduction. Although all our judges today need no introduction, but it's my honor to first introduce Dr. Lakshmi Mahesh. She is a visiting consultant at Sakra World Hospital and Netradhama Super Speciality Eye Hospital, Bangalore. She has been a pioneer in the field of orbit and oculoplasty and played instrumental role in establishing these services at SN Chennai and Manipal Hospitals, Bangalore, wherein she served as the head of the services. She's a visiting scholar, Chinese University of Hong Kong, and has trained doctors in Hong Kong and China. And she's a visiting consultant at Emirates Health Services for the last 2 years. She has served as President OPI in the past. She's a passionate teacher and mentored several fellows across globe. Welcome on board, ma'am. Then we have Professor Ruchi Goyal, ma'am, who has been into
Thank
teaching.
you very much.
Yes. Then we have Professor Ruchi Goyal, ma'am, who has been into teaching for more than a decade. She has also been consistently dedicating her Sundays for the cause of teaching oculoplasty through this webinar. She is currently a senior consultant at I7 Group of Hospitals, Lajpat Nagar, and visiting consultant Rajiv Gandhi Cancer Institute and Research Center, New Delhi. She is an ex-director professor at Maulana Azad Medical College, New Delhi, and examiner of FRC Offs, London. She is a reviewer of OPRS, Orbit, Cornea, IGO, BMJ, Clinical Ophthalmology, Saudi Journal of Ophthalmology, Eye, Current Eye Research, BGO, and Eye. She has more than 100 indexed articles in journals and more than 33 book chapters to her name. She has won various academic awards like VP Chadda Memorial University Gold Medal and Srimati Rukmani Gopalakrishnan Memorial Gold Medal, and AIOS APO Honour Award for Best Paper in Lacrimal Session, and AIOS IGO Silver and an outstanding paper by International College of Surgeons. Welcome, ma'am. Last but not the least, we have Dr. Anasua Ganguly Kapoor, who is a highly accomplished surgeon and our mentor at LVPI. She is an excellent teacher and currently heads KVC campus and Hima Bindu Yala Manchali Center for Eye Cancer at LVP Vijayawada. She is also the head of ophthalmic plastic surgery services and ocular oncology at Vijayawada. She has done her MBBS from NSMC Kolkata with gold medal in surgery in 2009 and completed her residency from AIMS in New Delhi in 2013. She has done her fellowship from LVPI Hyderabad. She also has more than 55 publications in peer-reviewed journals as well as book chapters. She has won several awards and lectures widely, nationally as well as internationally, and she has a keen passion for Indian classical dance. Welcome, ma'am. So welcome to all of you. I would now request Shruti to introduce the first speaker and kickstart the session.
Dr. Shravani, you can share your screen.
Yeah, so now we have our first speaker, Dr. Shravani. So everyone will be given 6 minutes to speak. So the timer will be strictly on, and please try not to, outtime your speaking time.
Yes, ma'am. A very good evening to one and all. I'm Dr. Shravani Vaisal, and here I would like to present an interesting case about a crystallized catastrophe. There are no financial disclosures. A 30-year-old male presented to our emergency department with a history of chemical splash injury to the face, which resulted in sudden onset eye pain, burning sensation, and inability to open the eyelids. This is the clinical picture showing that there was a chemical splash and all the chemicals are lodged over the hair, face, and over the eyes. Ocular examination of the right eye revealed that he has a vision of 6/6 and normal intraocular pressure, and the eyelid shows lid edema and chemicals that are stuck over the lashes and the diffuse conjunctival congestion. Ocular examination of the left eye revealed that there is fragments of solidified chemicals at the eyebrow, eyelid erythema and edema, and a large solidified foreign body which is whitish in color and it has filled all the fornices, and rest details could not be examined. So first thing first, we need to protect the right eye. We went ahead with copious and thorough wash of the right eye with saline, and we tried to remove the chemical particles stuck to the lashes, and he was started on topical medications. So what next? How to proceed for the left eye? Then we went ahead with the investigations. First, NCCT head and orbit has been done. This is the axial section of NCCT head and orbit, revealing that there is a large hypodense foreign body which is seen anteriorly to the globe, conforming to its contour. And the globe appears intact, and optic nerve is also intact, and there is no sign of intraocular foreign. So what are the management options? We took the help of Ocular Pharmacology department and went ahead to check out if chemical dissolution is an option. So we had tried water, polyethylene glycol, and even corn oil to check if the chemical can be dissolved or not. So first they were taken onto the slides, and this is the PEG 400 that has been used. And unfortunately, out of all this, there was no sign of any dissolution by these agents. So the option of chemical dissolution has been ruled out. So what's the plan? We had finally made a decision to go ahead and evaluate under general anesthesia the foreign body removal, and we have placed cornea and sclera as a backup in case there is any scleral or corneal breach, and the last resort would be evisceration or enucleation in case the foreign body could not be removed. These are the intraoperative findings. Following which, these were the post-operative orders. We have given systemic and topical management for the chemical injury of the left eye as well as the right eye. This is the 1 week post-operative picture showing that there is lid edema and a vision of 5/60 and resolving corneal epidefect. This is 1 month post-op picture showing that there is a still central corneal haze that is persisting. This is the 6 months post-op, which revealed that the patient had a vision of 6/18 central corneal opacity, which involved the epithelium and the anterior stroma. And patient is planned for a corneal intervention in the near future. So coming to discussion based on our case, what exactly is the chemical? That is all we want to know about. So it is actually a combination of MDI and polyol, that is methylene diphenyl diisocyanate. It is a compound which is commonly used in the manufacture of polyurethane products. So when MDI and polyol is mixed, it results in the formation of a solidified mass which is used as a foaming agent. These are the wide variety of applications where it is seen as an insulating agent for use over the floors or in the walls, and even for insulation of the refrigerated trucks, and even as a waterproof insulation. These are few reports. As such, there are no reports on solidified chemicals, but these are reports showing the role of isocyanates and their chemical injury, which showed that it can lead to even injury of the entire eyeball. And these are the hazard summary of MDI, which on chronic exposure can lead to asthma, dyspnea, and even chemical impairment in the workers. So overall, I would like to summarize saying that for a case, in case we come across solidified chemical injury, sorry, we should understand the unique nature of the chemical, because in our case the chemical polymerized into a rigid mass and irrigation was not of any use. Later on, we should appropriate use investigation such as imaging, and next we should precisely perform the surgery that would result in the success. And as we all know, prevention is better than cure. We need to advise all the workers to use a safety PPE kit while they are at work to prevent such injuries in the future. The final take-home message is MDI polyol chemical injury is a very rare injury which do not come across in our day-to-day life. So thorough preoperative management, strategic planning, and preparedness will help us for a better outcome. These are my references.
Thank you so much, Shravani, for that wonderful case. So just wanted to
Thank you,
remind
ma'am.
everyone, Dr. Shravani is currently the senior resident in Oculoplasty and Ocular Oncology at the RP Center, AIMS, New Delhi. And the mentor for her is Dr. Sahil Agarwal, who is currently the assistant professor in ophthalmic plastic surgery, aesthetics, and oncology at the RP Center, AIMS, New Delhi. So, do
Uh,
we have Dr. Sahil here? Would you
yeah,
like?
I'm there. I
Yeah.
would just request Shravani to add a word or so regarding the video. We were not able to hear the music part in the video per se. We were just able to hear see the video, but we were not able to know what you were doing on table then.
Oh, I
You just
thought
say
video
it
was.
yeah.
Yes, sir. I thought the video was playing. I'll just play the video again,
I think the
if
sound is
that
not
We'll
audible.
works.
first request the Dr. Ruchi ma'am and Dr. Lakshmi Mahesh ma'am to ask their questions and comments, and after that we'll move to the video.
Yeah, ma'am. Can I go ahead? Okay, please finish, Ruchi. Please.
So, a very nice presentation, and I just, the points to be highlighted here. I don't know why you kept, thinking of chemical dissolution, because I guess once you were not able to wash it off, the first thing is to take it off, because the sooner you remove the foreign body, the lesser the chances of penetration and causing limbal ischemia, because that's a concern with all these kind of foreign bodies. The other thing was that the most important part to be emphasized here again is that the story may not be over. You need to keep a watch for a longer time, because limbal ischemia, long-term changes like secondary glaucomas can occur, and corneal decompensation can occur. And of course, the protective gear, which is sadly missing in India, is a cause of many of these, not only industrial but farmal, for these agricultural injuries. All these injuries are basically related to lack of wear of protective gear, which in India people are particularly not following. So otherwise, a very well managed case, and I think that's the standard protocol of removing, washing, putting an AMT, and following up the patient. Ma'am, please.
Yes.
First of all, thank you, Aishi, and thank you, Yosi, for this nice opportunity. Shravani, right? She presented it
Yes, ma'am.
extremely well, diligent, wonderfully managed. Lastly, that amniotic membrane, how long did it stay before the cornea cleared up to some extent? And the
Ma'am, it
most
stayed at
important thing
least.
is, when you put the amniotic, soon after that, you have put in a conformer. Please realize a conformer in a seeing eye can be disastrous. You have had within 24 hours, patients develop corneal opacity. So this I've done, and maybe our within inner teamwork burnt my finger, and I'm telling you this. So confirm a simplifron ring would have been ideal in this case, with a large central opening for the cornea, because here the smaller openings won't suffice. So from this part onwards, I wish to know the management. That is one question. Question number two, how exactly was the analysis done subsequently when you took out the solidified particles? Just a very brief. I'm not going to do any chemistry, or we are not expected to know that, but for the knowledge, for the completion. So how did it exactly heal? Beautifully managed, very well documented. So, but these 2 points are my queries.
Ma'am, we have placed the conformer at first, and we have removed it within a week. So, and we could see that the amniotic membrane had like self-absorbed within like 3 months. And later on, after removing the chemical, we have sent for to our pharmacological department only for further examination. And we have also inquired from the relatives and the patient regarding the exact constituent. So they could actually bring the chemical which they have used at the industry, and that helped us in further review of literature and to know more about the chemical. So from that, we could make an idea regarding how to manage it in further instances if we come across such cases.
So since the amniotic membrane was not sutured, you're put in a conformer, but please in future kindly put a simplifier
Sorry to interrupt, ma'am.
every day you have to monitor the cornea. If you have put a conformer, even if you have put a simplifier ring, you have to monitor the cornea every day. And remember, you're also shown a temporary tarsorrhaphy in this case. So I don't know
Yes,
how
ma'am.
exactly you monitored. So that is a little bit dicey. Please keep this in mind.
Yes, ma'am. I'll
Did you
definitely
release the
take your
temporary
advice.
tarsorrhaphy the next day itself?
Yes, ma'am. We have released it in 1 week, but I have to mention that, sorry, my audio was not available in the video, I guess. We have sutured the amniotic membrane, ma'am, with the help of atovicryl to place it. We have sutured this one, and then to prevent any symblepharon, we have placed the conformer. But I agree, we should have placed a symblepharon ring. I would take that advice in future. I have removed the tarsorrhaphy within a week.
Excellent. Very good.
Dr. Sahil,
Thank you.
do you want to
So
add your
just to answer
comments?
Dr. Ruchi ma'am's query, ma'am, so we were quite lucky that the patient had presented us in the day hours. So the thing of dissolution, so the patient was immediately taken under GA.
I'm
We
sorry to
tried to do
interrupt,
a
Sahil.
copious
Even you are
irrigation
not
there.
audible. It's very muffled, the tone.
Okay. Right now, ma'am, is it audible?
Yes, Dr. Sahil, it's audible. Maybe you can speak a
Can
little
you speak
louder.
Little
closely?
better, little
Right.
better.
Right. So, ma'am, so we were quite lucky to have the patient in the morning hours itself. I mean, it was not really late evening, so we had the pharmacology department open with us, and things run parallelly. We took the patient immediately for under GA. Because it was quite stuck, so we're quite apprehensive about altogether removing the foreign body without without any general anesthesia. It was quite painful for the patient. And at the same time, on table, we did a copious irrigation, and meanwhile, the foreign body was sent for analysis in the pharmacology department. So there was no much of a delay. So the irrigation happened as parallel as the dissolution of the chemical thing was tried in the pharmacology department. And once the patient was intubated, what Shravani was telling was that, ma'am, we thought the foreign body might be totally stuck to the lid, it might be totally stuck to the ocular surface, the cornea might be involved all together. But to our surprise, the foreign body came out very gently. It didn't react with the ocular surface. So, I mean, various foreign bodies react differently, and we were quite lucky in this case that the foreign body had not made up any reaction with the local tissue there, and we were able to salvage the group very well.
No doubts about the surgical management. Excellent, Sahil. Wonderful.
Thank you, ma'am. Thank you so much, ma'am.
You don't have to explain all this, but great.
Dr. Anuswa, do you have any comments?
Yeah, first of all, it's absolutely heartwarming for me to see our star fellows, Ayushi, Juhi, and Shruti, doing so well with Yosi and taking it to the next orbit. And my junior at RP Center, Sahil, managing this case and mentoring Shravani so well. So, congratulations on that. So, the only thing I wanted to stress, which Dr. Ruchi has already touched upon, that the time interval between the exposure and definite removal is the key here and has a significant impact on the limbal ischemia and the long-term prognosis. So the while the pre-op pharma testing to assess solubility is noteworthy, I'm unsure, like, even if it was soluble, how would we have used those chemicals? Because those chemicals, we are not sure how they will themselves act on the eye surface. So I understand that in RPC both can go hand in hand. So you just tried out that option, but I am a little doubtful about the usefulness of that solubility testing.
Ma'am, actually, we have asked for the safety of the chemicals. So, generally, polyethylene glycol was used as a solvent in routine eye drop making, and corn oil also was used as a solvent for in dry eyes. So, we have asked for the safety, and just for that purpose, we have just tried in case that would help us during the
Okay, then
management.
it's great. Like you have already looked into the safety profile of those solvents, is what you're saying. Okay.
Yes, ma'am.
Thanks, Sahil
Thank you.
and Shravani.
Thank you, ma'am.
Thank you, Dr. Anuswa. Dr. Shruti, you can go ahead.
Yeah, thanks, Ayushi. Thank you so much, Dr. Ruchi, Dr. Ansua, and Dr. Lakshmi for the valuable clinical insights. And thank you, Shravani, for that wonderful case. So next online, we have a farming misadventure where ulcer meets neoplasia is to be presented by Dr. Megha. Dr. Megha is currently doing her Oculoplasty and Ocular Oncology Fellowship from the Center for Sight, Hyderabad. And the mentor for her is Dr. Rolika Bansal, who is currently the consultant oculoplasty ocular oncology at the Mahatma Gandhi Eye Hospital, Jaipur. Dr. Megha, all yours.
You're muted, Megha.
Am I audible now?
Yes.
Okay. A very good evening, one and all. I'm Dr. Megha, and today I would be presenting an unusual case of ocular surface squamous neoplasia. So, very often in a busy OPD, we can come across a farmer who comes with a farming injury, and we could be looking at it as a simple corneal ulcer, but missing something far more sinister creeping right next to it. Yeah. So OSSN is the most common neoplasia of the ocular surface. It is a limbal stem cell disease and a clinical continuum of precancerous to cancerous epithelial lesions of the conjunctiva and cornea. With a diverse list of incriminating associations, it is usually unilateral. When bilateral, it is usually associated with HIV immunosuppression, xeroderma pigmentosa, and palmoplantar keratoderma. OSSN is a disease of the conjunctiva, cornea, or both together. Now, these can present to us in one of its many forms, such as papillomatous, leukoplakic, gelatinous, nodular, diffuse, or pigmented. With this background of OSSN, let us approach this case of a 74-year-old farmer who presented with pain, redness, foreign body sensation in his left eye following a farming injury 1 month ago. He was treated with topical medications for corneal ulcer at a nearby clinic, but there was no improvement and further deterioration of visual acuity, for which he was referred to our center as a suspected case of OSSN. On a closer look, we could appreciate a brown corneal opacity with feathery margins and stromal hydration, and overhanging the temporal edge of the corneal opacity was a fleshy gelatinous conjunctival elevation with petechiae. The junction of the two lesions stained positive for rose Bengal. To further assess the inflamed thickened conjunctival lesion, we checked for the three other hallmark signs of OSSN and noted keratin intrinsic vascularity with prominent feeder vessels and episcleral and corneal fixity. Corneal scraping of the ulcer confirmed demetaceous fungal corneal ulcer, and there was significant clinical improvement with 3 weeks of topical medications. After clearance from the cornea consultant, we proceeded with complete surgical excision of OSSN with 4 millimeter clinically clear margins, alcohol assisted keratoepitheliectomy with supplemental cryotherapy to the bare sclera and the conjunctival edge, followed by careful ocular surface reconstruction with amniotic membrane graft. Now, this could be very deceiving with a beautifully healed ocular surface with no evidence of residual tumor or recurrence, but histopathology reported a positive base, and hence adjuvant therapy was planned in the form of a secondary plaque brachytherapy. At 2 weeks post-plaque, our patient is back at the farm with a visual acuity of 6/9. So while OSSN is notorious to present as one of its many masquerades, especially a corneal ulcer, OSSN coexisting with corneal ulcer is rather rare, and literature recognizes it as a challenge with poor prognosis. However, we followed a methodical approach to control the active fungal ulcer and then proceeded with surgical excision of OSSN and further treated the stromal invasion with secondary plaque brachytherapy. And at 6 months post-op, our patient is tumor-free. It could be an OSSN which is staring in our face, a masquerade, or one with coexisting pathologies. But this holy grail to identify OSSN will never fail you. Once diagnosed, always assess the depth using ASOCT or UBM, and when in doubt, always of orbital extension, always get an MRI. The gold standard treatment for OSSN has evolved from wide margin surgical excision to topical immunotherapy and plaque brachytherapy. To sum it up, OSSN is strictly a clinical term and should not be used in histopathology reporting to prevent misinterpretation. We must always check for abnormally thickened limbal conjunctiva with hallmarks of OSSN in all its mimics. Never forget nodes. Always respect the oncological principles. When two pathologies coexist, we must always prioritize aggressive tumor control before any other surgical intervention to prevent intraocular or orbital spread. Thank you.
Thank you very much, Dr. Megha, for that wonderful case. I would like to ask Dr. Anasua for her valuable comments first.
Yeah. Hi, Megha and also Rolika. Fantastically managed case and great documentation. As a resident, this is absolutely fantastic. The way you showed the photographs, the way you documented both the regions separately, the way you described them. So full marks on that. As you said, this is a very rare coexistence of OSSN along with microbial keratitis. Our series showed that only 2% of our patients had this. So at this juncture, I would like to ask you, Megha, like what is the more like in your opinion, what is the most likely cause of this coexistence? So why OSSN causes microbial keratitis? Did you look into literature, the pathogenesis?
Ma'am, since it is an ocular surface disease, it could alter the flora, the microbial flora of the ocular surface, and OSS in itself could cause corneal changes, which could predispose it to an ulcer. So that could be one of the causes why it could coexist
What's the
commonly.
corneal
And the
change?
limbal
What's
stem
the
cell.
corneal change?
Yeah, what is formed in cornea, which like if you look into the series you just talked about, what the majority of the patients had prior to developing the microbial keratitis in the cornea.
Ma'am, it's a limbal stem cell disease, so the limbal cell architecture could be disturbed, and it could disturb the tear film stability, all of which
Leading
could
to?
cause.
That's the first answer you should give.
Yeah, the tear film stability would be disturbed, which could cause corneal epithelial irregularities, and hence an ulcer
Yeah.
following it.
Also, what we found in our series was there was the Dellen formation prior to
Yeah,
development
it
of this
was.
microbial cavity. Big secondary to tear film changes, Dellen formation, which in its turn got infected. So that's the usual pathophysiology. So now, what is the most important factor in treating this coexistence, Meghna? Like you have a localized OSSN along with MK. What
Yeah.
is the first thing you will look for in this lesion?
Ma'am, we first need to first we will start with medical management for the for ulcer, because that can be done along with the tumor. But
Oh, you
along with
talked
that,
about the algorithm, Meghna. So, what
yeah.
are the two important things in the algorithm which your audience needs to know in this coexistence, which helps us guide the management or uh, form the customized care for this patient? So, the two things you look for in clinical assessment.
One, we need to rule out an intraocular or orbital extension.
Correct. Very good. How do you rule out clinically an intraocular extension?
Clinically, intraocular extension. Ma'am, on slit lamp, we can look for any scleral breach or episcleral fixity could be one way
Correct.
to check
What
for
else?
its episcleral fixity. The corneal fixity, stromal hydration could show that the cornea was, of course, involved with this.
Any AC cells,
Yes.
any secondary glaucoma.
Yes, ma'am.
Yeah, Meghna. Yeah. So the next thing, so intraocular extension is one. The second thing we look for.
Orbital extension, so we need to do
Yeah.
imaging for that.
Okay, so we are talking about localized cases. So one is talked about as intraocular extension. Second thing, the visual potential. So visual potential, we rule out corneal perforation. If you looked into the algorithm you just showed, these are the topmost thing we look for before planning the customized care for this patient. So thank you, Meghna. Thank you, Rolika.
Thank you, ma'am.
Thank you, Dr. Answa. Can we have Ruchi ma'am
Yeah.
give? Yeah.
Yeah,
Please.
very nicely managed case, Megha and Rolika. Just a couple of points. A fungal ulcer. One thing is that already the patient had a limbal stem cell deficiency, but in a farmer, a fungal ulcer of that kind is so common. If you ever have worked in villages, you will get to know that it is left and right, you keep getting those kind of cases. So possibly the ulcer would have been there for quite some time and the ulcer was not healing and it was referred. The second thing is that these ulcers are usually very recalcitrant to treatment. So was it justified that you waited for 3 weeks? Like, why not go ahead and at least remove the surgical part? And because sometimes the healing, you were lucky enough that you got over your fungal infection treatment in time, but sometimes these patients, the fungal ulcer tends to persist for weeks and months together. So was it a good idea that you go ahead and remove the at least the OSSN part and simultaneously treat? Was that a thing in your mind ever?
So, ma'am, in our case, we were lucky that there were the time duration in which the farmer presented to us and the duration of symptoms was not that long. So it deserved a shot at medical management before we could proceed with surgery. So we just decided to begin with treatment and see how it responds. Of course, if it would take much longer, then we would have to prioritize oncology over the fungal ulcer control. But in our case, we got lucky and hence we could manage it the way we did with control of the ulcer followed by excision.
And may I add an additional point, ma'am? Additionally, if at all we would treat along with it, it can cause corneal architecture loss, like because it can cause a corneal melt if the integrity is not good, strong enough. Because we have a plan of brachytherapy as well, so we had to give it a healing time, and so that we can proceed with brachytherapy. Because and on ASOCT, we were suspecting an invasion, which was cleared and clarified on histopathology with base invasion.
So, Rolika, you mean to say that the brachy was planned earlier itself?
It was thought of,
before the
but
excision?
ma'am, we do it two ways. We do it as primary brachytherapy or secondary brachytherapy. Primary brachytherapy is that when at all we know that imaging has been cleared, that is ASOCT or UBM have cleared that yes, there is an invasion. If there is a suspected invasion, like plus minus, then we rely on histopathology. And if at all histopathology confirms, then we choose it as secondary brachytherapy. And in this patient, we also did say secondary brachytherapy as a preference because we were giving healing time, because we do secondary brachytherapy after a few weeks. So that is why it was a better choice, because we did not want to cause inadvertent thinning and melt.
Was the fungus demonstrable on KOH?
Yes, ma'am, it was demetaceous fungal corneal ulcer, which was confirmed on scraping.
And the culture also was there, because sometimes when it's a little bit we call it a contaminant also. So fungal culture also came positive.
Yes, ma'am, this was the culture was positive, but it was also sensitive to the medicines which were being given, which correlates with how it improved so well with the medical management.
However, the culture came positive way later, ma'am, because it takes time to grow,
Yeah,
but it was anticipated.
It takes time. That's why I asked you. Sometimes it even takes a month.
Yeah.
So if it's nothing like we don't fully rely on KOH mount, because sometimes we are worried whether it's a contaminant. But anyway, beautifully managed, and I think the patient has also done very well.
Ma'am, the 7, 10, and 14th day report were negative. The one after that 28th day is when it came as positive.
But so only after 4 weeks it came out positive.
Yes, ma'am, because the first 3 were negative, right?
So
it
came as positive.
Sorry, ma'am, I didn't get a question, ma'am. Your voice was breaking.
KOH mount. That I mean the smear.
Yes, positive.
KOH for KOH.
Yes. Yes. Yes,
It
ma'am.
came out positive.
That was positive, yes, ma'am.
Okay. Based on which you treated. So you didn't wait
Yes.
for 28 weeks, I'm sure. 28
No,
days,
no,
I'm sure.
no.
Right?
We talk
And
about
what has
culture
been the
coming into.
follow-up protocol of such a patient?
Ma'am, the patient was planned for plaque, and then after that, after plaque brachytherapy, we followed him up at 6 weeks, and then another 6 weeks, and then 3 monthly. So right now, he was recently followed up, and he's doing very well.
Generally, all these surface tumors, eyelid tumors, generally, I'm sure Santosh has taught you all, but to reiterate, it's every 3 months for the first 1 year,
Yeah.
every
Followed by
6
4
months for the
months.
second year, and every year, third year onwards.
Yes,
Good.
ma'am.
Yes, ma'am.
Yes,
Very
ma'am.
much so.
Thank you very much, Megha, for that wonderful case. Thanks to Rolika for the proper guidance. And thanks to all the judges for the insightful feedback. Now I invite Dr. Juhi, my co-moderator, to introduce the next speaker.
Thank you, Shruti. So our next presenter is Dr. Shumaila. Dr. Shumaila Khan is currently a resident at NKP Salve Institute of Medical Sciences, Nagpur, and she's mentored by Dr. Gaurav. Dr. Gaurav Patil is a fellowship-trained oculoplasty and ocular oncology specialist from LVP Hyderabad, and he's currently a consultant at NDP Eye Care Nagpur and a visiting consultant at NKP SIMS Nagpur. He is skilled in advanced cataract surgeries, endoscopic DCR, facial aesthetics, orbital and eyelid surgery with multiple presentations and publications. Please go ahead, Shumaila. Shumaila, you're not audible.
You are not audible.
A very good evening to one and all. At the outset, I would like to thank UC for this opportunity. I'm Dr. Shumaila Khan, a second-year resident of NKP SIMS Nagpur, and I'll be presenting a case of medial canthal mystery. A 73-year-old gentleman, resident of Savner, Maharashtra, presented to our Ocular Oncology clinic with chief complaints of mass in the left eye since 6 months, which was gradually progressing in size, and it was not associated with any pain or watering. The family, systemic, and personal history was insignificant to the presentation, and he denied any history of trauma. On examination, we could see a 15 into 15 into 5 millimeters elevated nodular non-tender mass with minimal ulceration. It was firm in consistency with restricted mobility at the medial canthus, and some mucus debris was noted at the caruncle, and Roplas was negative. His best corrected visual acuity in both the eyes was 612 and N8, and rest of the anterior and posterior segment examination was within normal limit, excepting some age-related cataractous lens changes were noted in both the eyes. As the mobility was restricted, we requested a CT scan of the orbit, which revealed a relatively well-defined iso to hyperdense lesion with irregular margins. The lesion was seen extending up to the ostium of left nasolacrimal duct, and the lacrimal sag was not seen separately. The lesion is also causing indentation of the globe, abutting the medial rectus muscle, so most likely suggestive of neoplastic etiology. Clinical impression of left eye basal cell carcinoma versus squamous cell carcinoma was made, basal cell carcinoma being the most common malignancy of the medial canthus. And the patient was planned for left eye excision biopsy with frozen section for margin control, along with reconstruction with a forehead paramedian flap plus DCT plus cryo of the margins. Intraoperative care was taken to remove the lesion in toto using no-touch technique, keeping a 4 mm margin which can be seen in image A. The no-touch technique was maintained, which can be appreciated in image B, and the image C depicts the removal of the lacrimal sac with the lesion. After removal, the lesion was sent for frozen section. After confirmation that all the margins and bases were free of any tumor cells, we started reconstruction, raising a forehead flap, paramedian flap, to cover the defect. This is the gross specimen. And these are the 10x and 40x images of the slides. On histopathological examination, the sections revealed malignant squamous epithelial cells with keratin pearls with infiltration into the underlying tissue. All the surgical margins and bases were negative. So diagnosis of left eye medial canthal squamous cell carcinoma with infiltration in the lacrimal sac was made. The defect was well sutured at the end of the procedure, and the patient was later sent to the oncologist where he received 30 cycles of immune modulation therapy to prevent metastasis. USG abdomen and HR CT were done, which were within normal limits. And coming to the timeline of the pictures, these are the clinical images of the patient at presentation and at postoperative day 1. The lymphedema at the graft site seems to be reducing, and so is the forehead scar at postoperative day 90. At 15 months, there is no local recurrence of the lesion with a satisfactory cosmetic and functional outcome. Lacrimal sac tumors are rare and can present as medial canthal mass with or without hemorrhagic epiphora. The malignancy rates of these masses are reported to be 55 to 75%. Bilateral squamous cell carcinoma can be seen in human papillomavirus and human immunodeficiency virus infections. The close approximation and presence of delicate yet crucial lacrimal apparatus is always challenging while reconstructing. The treatment options include surgery, radiotherapy, or chemotherapy. The most important is having a good marginal control. We report a case of medial canthal mass which underwent excision biopsy with frozen section with DCT with reconstruction using paramedian forehead flap, which was followed by immunomodulatory therapy by the oncologist. To summarize, clinical examination with radiological correlation is critical for surgical planning. Excisional biopsy by taking 4 mm margin. Adjuvant therapies are required to prevent metastasis. Histopathological examination is the gold standard. Follow-up of oncology cases is lifelong. These were my reference articles. Thank you so much for your patient listening.
Shumal, I love that you made the illustration of the lesion in the plan yourself.
Can I
sorry,
please
ma'am.
see your first 2 slides if you don't mind? I
Okay,
just missed
yeah.
the first 2 slides. Your title slide also.
Dr. Shumala, the first 2 slides.
Yes, ma'am.
Meanwhile, Dr. Lakshmi and Dr. Anuswar, do you have any questions?
Yeah.
By the time she's sharing.
Sometimes we wonder when we see a sac tumor, whether we have to choose between the devil and the deep sea. Because we are always taught as oculoplasty students or residents that the lacrimal gland tumors are the most sinister in the orbit among all the orbital tumors, but it's not so exactly, because lacrimal sac tumors are extremely rare. Can't immediately remember that article, but there was a series of about 650 or 700 patients where they routinely sent, I think it was from the US, for biopsy of the DCR DCTs, and they found that there were only about 3 malignancies or 2-3 malignancies. Now here was DCT already planned before you went in, is the thing. Imaging beautifully showed a lacrimal tumor, no doubt. Was DCT already planned?
Ma'am, as we could see in the CT scan that lacrimal sac involvement was also there, plus the histopath had later on also revealed lacrimal sac involvement. So we had already planned DCT.
In which case, while excising the sac, while removing the sac, was there an addition around? Because all is not great. Whether I don't mistake me, are you justified in reconstructing in the first sitting itself is the question, because lacrimal sac malignancies are extremely sinister. Please realize that lacrimal sac has a different histopathology. It has a transitional cell histopathology, just like the urinary bladder. And the carcinomas of the lacrimal sac are much more sinister. They are very rare sinister. So that's why I said whether it's gland adenoid or adenoid cystic carcinomas are more sinister, or this, I would say sac, because it looks so harmless, one small swelling, blah, blah. But they are so difficult to manage. It's been beautifully managed, no doubt. But I'm just asking aloud because they're so rare. We have to also be very clear as to what was in the mind, the surgeon's mind. And point number 2. So are we justified in reconstruction in the first sitting? That means in DCT, in a normal DCT itself, when we do it for a very bad sac or for a tuberculosis sac, it's so densely adherent all around due to the repeated infection and inflammation. That's why I'm asking you. And generally in this case, there wouldn't have been much of infection in and maybe even for all possibility, syringing, if you had attempted, might have been clear. And you know that the lacrimal bone is so thin, so chances of spread are very likely. So are you, coming to the second question, which is a follow-up of the first, are you justified in starting the new adjuvant a little earlier itself? Because we know that squamous cell carcinomas melt with radiation. So maybe a little bit of chemo radiation to begin with and then do the surgery. I know, I'm just asking you.
Thank you,
Ma'am,
Dr. Lakshmi. Can I take that question?
Please.
Yeah, so when I saw the radiological imaging, the lacrimal sac was not seen separately. So it was in my mind that I would probably on table decide whether I have to do a DCT or not. The initial planning was just excision biopsy with frozen section and cryo to the margins, and reconstruction was could be decided. But the sac was removed totally, and as you said, the lacrimal bone was also intact. And once I sent it for the frozen section, I asked them for the margins also and for the base. The margins and base both were clear, and hence we decided that we'll reconstruct it in one sitting only.
Sorry,
And
I'm really sorry I have to interrupt. Where is the margin in this case, Gaurav? Where is the margin? Where is the clear margin? Like in eyelid tumor, you leave 2 millimeter, 3 millimeter. In a sac, I just want to know where is the margin? It's your orbicularis muscle on one side, it's the bone on the other side, it's the medial canthal ligament, a part of it, and just above that is the fundus. You have to sever the ligament if you want to do justice and take out the fundus of the sac also, and then it goes down to the NLD. Now, where exactly, what do you mean by margin?
the margin was taken on the eyelid, not on the sac, and hence it was sent for the
Okay.
pathologic. Yeah, it was
So
sent
you
for the
also
pathology.
took out, you sent the base also.
Yes, yes,
So
yes,
you took a
yes.
little bit of the, now coming back to the clinical picture which she has projected, how many millimeters did you leave laterally? How many millimeters medially? How many millimeters superiorly, inferiorly, and at the base? So you have 5 margins here.
So
Am I
all,
right?
yes,
One, we don't have to really worry. The lateral, which is there in the canthal area, don't have to worry. But of course, in the lower lid, you would have to. What is spilling to the lower lid?
it was. I don't know if she has the picture, but
Yeah, she
on
has it
mark.
on. She's sharing that screen only now.
No, no, no. There was one more picture that I took before. Yeah,
Okay, okay. Please,
yeah.
please show that.
So I had marked it. The base was not marked, but
Base you
I,
can't mark. Yeah.
yeah. So I removed it as much as I could in toto, and I just could ask the pathologist to tell me whether they could see any tumor cells or not.
The one you
And
show, the C is beautifully demonstrated, where the medial margin, I think at least 3 millimeters you have left there. That's very beautifully demonstrated. I think inferiorly also you have given about 2 to 3 millimeters.
I
And
tried to
very
do
nicely
as
done,
much.
very diligently and nicely done. Only thing is, I'm still surprised that it was not adherent to the surrounding structures.
Yes,
Excellent.
yes, yes, yes.
It was not. You had you had a nice space. You had nice place to dissect and take it out.
Yes, yes,
Okay,
yes, Dr.
very
Lakshmi.
good.
Thank you so much.
Dr.
Yeah.
Anasua, do you have any questions?
Yes, yes. So, a great job, Sumaila and Gaurav. Fantastically managed case. So I had three comments. One is in the preoperative evaluation, Sumaila, you showed the photographs. Those photos were not showing the lacrimal sac or the NLD cut section. It will be good to show those photos as well. But Gaurav talked about involvement of the lacrimal sac, which he saw in the CT scan. So I am assuming the lacrimal sac involvement was preoperatively only assessed. But one thing which should be a mandate and should be included in preoperative evaluation of such cases, Gaurav, is a nasal endoscopy. While we do it in our own setting, if you don't have an endoscope, it is good to get a ENT opinion done, because if there is a nasal extension, we should go ahead and do a combined excision through endoscopically and externally what you have done.
As
So
an
that is one.
extension to one interruption to Anusuya's excellent point, a CT DCG can also be
Sure.
Yeah. And the second point is I compliment you, Gaurav, on doing a single stage procedure because you did a frozen, what I understood, you did a frozen section and did a margin control, and those were on negative. That's why you went ahead and did a single stage procedure.
Yes.
The third point I have is I think Sumaila could have given some more clarity on the histopathology post-op, because that is the most important thing guiding us in the post-operative adjuvant therapy that we do. So, like when we take out such tumors, what we routinely do is we take a small snip of the NLD, at the soft tissue NLD at the cut margin, and send it separately to the pathologist so that they can opine on the soft tissue NLD involvement. Also, we do some scraping at the bony NLD that is left behind so that they can opine on both the bony NLD and soft tissue NLD involvement. Apart from that, we need to look into the the histopathology. We should have mentioned about the NLD involvement, the perineural invasion, anywhere else, like any base being positive, the base left behind, we also take some tissue from there. So any of these being positive is an indication for the post-operative adjuvant therapy. Usually what Dr. Lakshmi was mentioning, we do a EBRT. So those are important things which you should include in the post-operative evaluation.
Sure.
So
Thank you,
coming
Dr.
back
Mansur.
to the
Yeah.
sequel of what Anusya said, so why wasn't a neoadjuvant considered pre-operative?
I was not very sure whether I was not very confident on the radiology also, the radiologist, whether it is really involving or not. And the frozen section told me that the base is not involved. And secondly, the final histopathological diagnosis showed whatever they said. They were not very well equipped with the ocular pathology, I suppose. The report did say that there is no involvement whatsoever for the base. When I called the pathologist, they said that there is no extension that they see in the NLD. And hence, I sent the patient to the oncologist for EBRT. But the patient was not affording, and the oncologist, I don't know why, but they said that immunomodulation therapy would be good enough.
Immunomodulation, what are you giving the patient for squamous cell?
I don't know. They did some isoretinoin or something for 30 cycles.
That is important because in oncology cases, we have to keep a tab. Again, we come back to the follow-up. So you will have to know imatinib. You mean imatinib is being given?
I will have to find it out because the
I don't
patient
think
lives.
so because squamous, the bed, even though they say it's clear, you will have to give some amount of radiation. You can
Yes.
give IMRT, focus on that particular area alone. This
Okay.
patient is in Nagpur.
Nearby Nagpur, but like I'll have to find it out and.
You have to do it. You have to do it
Yes,
because
yes.
later on somebody else may be radiating or something, and when the surface changes develop, then they will send the patient back to you. Then it'll be very difficult for you to handle at that stage. So please get back the records, and I think he will need radiation to just focus radiation to that area without much spillover. You can usually discuss with the radiologist, and these days you don't have to give all those 25 30 things. You can beautifully tailor make. It's all the play in the LINAC. So you take your radiation oncologist into confidence and please work on it, and I'm sure
Sure.
you will have to do that. Otherwise, there's going to be a recurrence, okay? Because you've
Sure.
also reconstructed. That's why I asked
Yes.
you that point. Never mind, but please consider this, okay? Thank you.
Surely. Thank you.
Thank you, Dr. Lakshmi and Dr. Anaswa, for very informative comments. Dr. Ruchi, do you have any comment?
Last comment there, I was not very happy with the immunomodulatory therapy at all. Actually, I don't think there is any role of it. Without, it is either you should have taken, have you checked any mutations, that any particular mutation the patient had, PDL1 inhibitors, but that also, if the whole thing has been taken out in totality, only thing that is required if there is a bony invasion is the radiation. There is
Correct.
absolutely no role of immunomodulation in this patient. But yeah. So
No, I had sent the patient for EBRT only. My requisition, I mean, everything that I wrote was EBRT, and I sent the histopathology report also. But I was also unsure that as to why they are doing IMT, and hence I said that it is according to the oncologist who was treating it.
When did you get a PET scan done? When was this patient
The
operated?
PET scan, this patient was operated last year. The PET scan was advised, but he was not affording. So USG abdomen was done and HRCT was done. It was done twice and it was negative. The nodes were also negative.
Okay, but again, we may miss out on local invasion and so many things. So I think the follow-up still needs to be a little, because even the immunomodulated drugs are very expensive. So
Correct.
instead of spending money on that, maybe the other things were more important. Anyway, very nice.
Sure.
Thank you.
Thank
So
you.
just a short comment, Gaurav. These are initial challenges that all of us have gone through, like the oncology is doing things and we not as per our protocol. So it's a good idea to interact with them more often. Maybe a tumor board sort of thing you can arrange between the whatever two centers, and then try to convince slowly. You can connect them to your the ocular, the radiation oncologist and all from your alma mater. That will be a good way ahead.
Surely, surely. Thank you so much.
So now we'll quickly move on to our next presenter, Dr. Farnaz Yassir, who is a fellow in oculoplasty and ocular oncology at Center for Sight, Hyderabad, India, and is mentored by Dr. Rolika. Please go ahead.
Hi, good evening. My slides are visible?
Yes.
Okay. So, hi, hello, and a very good evening to one and all. So, the last speaker of the session. So, let me tell you a story of resilience of the ocular surface tumor and the ocular oncologist. An elderly gentleman in the 6th decade presented to us with recurrent redness in the right eye since 4 months, already biopsy proven to be ocular surface squamous neoplasia, and initiated on topical chemotherapy with 0.04 mitomycin C, which he used last like 1 week ago. Visual acuity was 6/6 in both the eyes, and in the right eye, there was a solid nodular lesion with the epicenter at the limbus and an associated limitation in dextroversion. And the slit lamp evaluation of the right eye showed this lesion, which was involving 7 clock hours with intrinsic vascularity, feeder vessels, rose Bengal stain positivity, and episcleral fixity as well. We went ahead with an ultrasound biomicroscopy, which had a maximum episcleral extent of 1.5 millimeters and radial extent of 6.5 millimeters at 7 o'clock. And anterior segment OCT showed typical features of OSSN with scleral invasion. MRI was also done, and it was suggestive of lateral rectus involvement up to 3 millimeters from the insertion. With the aforementioned, treatment options included extended enucleation, exentration in view of muscle infiltration, or chemoradiation. However, owing to our previous experience, we decided to proceed with complete excision of the tumor followed by plaque brachytherapy in the same sitting. So this video demonstrates the excision of the entire lesion, inclusive of the lateral rectus involvement, following all the oncological principles. And in the same sitting, plaque brachytherapy was done with the tumor apex dose of 6,000 centigrade and 3 millimeters depth, covering 6 to 11 o'clock first, followed by rotation to 9 to 2 o'clock and 4 to 8 o'clock. During plaque removal, edge and base double freeze thaw cryotherapy and lateral rectus reinsertion was done, followed by ocular surface reconstruction with amniotic membrane and glue, and symblepharon ring and suture tarsography as well. So the plaque brachytherapy in 3 rotations was done as depicted in the pictorial representation here, and histopathology as well confirmed the OSSN with base involvement, loss of continuity of the basement membrane, tumor infiltrating into the underlying stroma, keratin whorls, and margins which were sent separately were also free of tumor. The patient was doing very well, and this is the post-operative picture 6 months later. But after 9 months during the post-operative period, there was a recurrence noted from the superior edge with scleral fixity. So we went ahead again with excision biopsy following all the oncological principles and plaque brachytherapy for this particular lesion with 6,000 centigrade dose, and this time for 2 millimeters thickness. Again, the patient was doing well until 4 months, and then he had recurrence at the same site. There were no predisposing factors for any OSS in recurrence. So for this particular lesion, again, we went ahead with excision and plaque brachytherapy, this time with 6,500 centigrade and 2 millimeters thickness. No regional lymphadenopathy, and PET-CT was also negative. And he was doing well after this. This is the post-op picture after 3 months. Then the patient presented to us after 8 months, and now this was a surprise. Suddenly, there was a visual acuity drop to 6/60, anterior chamber inflammation, NS2 cataract, obviously because of the age, neovascularization of the iris, and thereby intraocular pressure was 32 millimeters of mercury. However, this time there was no local tumor recurrence, anterior chamber, angle, ciliary body on slit lamp and UBM, everything was normal, and a normal posterior segment. Fundus fluorescent angiography also was done, and it turned out to be normal. So after extensive literature review, we decided to proceed with 3 injections of intravitreal anti-VEGF for neovascular glaucoma. Probably that has happened because of anterior ischemia. Anterior segment ischemia. And after this got resolved, safety enhanced cataract surgery was done, and the patient's vision improved dramatically to 6/9. So during his last follow-up, his vision was 6/9, and the anterior segment evaluation and imaging also showed no local tumor recurrence, no regional lymphadenopathy after 4.5 years of follow-up. So aggressive management of recurrent OSSN with surgery, plaque brachytherapy for local tumor control, while intravitreal anti-VEGF to manage secondary complications like neovascular glaucoma led to a successful outcome in a particular case. So how did we start? Recurrence, recurrence, and recurrence. And how did we conclude? Globe salvage despite the options of excision or extended enucleation. With surgeries, recurrent plaque brachytherapy, and neovascular glaucoma. And there was no local tumor recurrence and excellent vision after 4.5 years of follow-up. And that's how we salvaged the unsalvageable. And that's what resilience was all about. Thanks a lot.
Juhi, you're muted.
Oh. Dr. Ruchi, do you have any questions for Panaz?
I'll just congratulate their perseverance on, working on this patient. I really admire it, and very, very well managed. I guess this can only be done at, I think, under care of Dr. Honavar, that you keep on working with the plaque radiotherapy again and again, brachytherapy, sorry, again and again, and do it so well. But yeah, you still need to follow up the patient because the story may still not be over. So it may be just a temporary delight that you have achieved. And otherwise, what about you're getting yearly PET scans done? What is your management protocol post-operatively now?
So post-operatively, he's on regular follow-up. So currently we have completed 4.5 years. So now the patient is on 6-monthly follow-up only. And he was doing very well. As of now, even until now, there were no systemic issues as well. No other involvement of the, no systemic involvement and no recurrence. So currently we are not going ahead with an annual PET-CT so that we don't subject him to radiation, because when he developed the third recurrence as well, that is the time, second recurrence as well, that's the time we went ahead with a PET-CT to rule out any systemic malignancy, and that was negative. So we are not subjecting him to annual PET-CT.
So simply one anti-VEGF injection took care of the secondary glaucoma?
No, ma'am, he required 3.
He required 3 injections. Is he still on anti-glaucoma drugs?
Currently, his pressures are controlled, ma'am, so it didn't require. So, so after the 3 anti-VEGF injections, almost a year he was on anti-glaucoma medications to keep his pressures in the borderline or even in the controls, because it was fluctuating from somewhere to 18 to 22. So after that, we had gradually stopped it.
Congratulations on a very well presented case. Of course, all credit to Dr. Honavar. Doctor, how many times can you do brachy? What was the interval between the 3 brachy's? Am I right, 3 or 4?
3 brachytherapies.
What was the interval between each of the brachy's?
The first one, the second recurrence was 9 months later from the time of the first presentation and the excision and plaque brachytherapy of the first sitting. So the second brachytherapy was at a duration of 9 months, and the next one was around 4 months. So there was a sufficient amount of healing, and also there was no scleral thinning noted during, whenever this plaque brachytherapy was actually planned.
Was anti-VEGF injections enough to bring down the ocular ischemia? How did the ocular ischemia per se improve?
So neovascular glaucoma was, in this particular case, it was probably because of the anterior segment ischemia, because of the muscle involvement and also multiple surgeries, especially plaque brachytherapy. And we had to manage it with 3 monthly injections of anti-VEGF along with topical medications, ma'am.
So he didn't undergo any other treatment other than the excision and brachytherapy, am I right? No chemo, nothing
Yeah,
else.
with us, he did not undergo any thing else, ma'am.
Very nice. Thank you.
Dr. Anaswa, do you have any comments?
Yes, Juhi. So for Naz, like it was absolutely a story of resilience, as you said, and an exceptionally well managed case. Any other surgeon would have, at some point of time, would have considered extended enucleation, which was not done in this case, and the patient is doing so well at 4.5 years of follow up. That is phenomenal. So, Farnaz, I had 3 comments and question for you. So first is, I think at the beginning you talked about the patient already being on mitomycin C when they presented to you, right?
Yes, ma'am.
Yeah, so
I
I
think
think it
her
will be
screen
prudent.
froze.
Oh, okay, Rolika. Yeah, so I think it will be very prudent to talk about that my topical mitomycin C in a case of OSSN with a scleral involvement is an absolute no-no or an absolute contraindication. That should be stressed to the audience that we only use this immunotherapy and chemotherapeutic modalities for OSSN cases, which are the run-of-the-mill cases with just an ocular surface involvement. Whenever there is scleral involvement, we can't use mitomycin C and we should resort to surgical options or a plaque brachytherapy. That is the first comment. Second, is she back, Farnaz?
No, ma'am,
So,
she's not there. I'll answer
okay,
on her
okay,
behalf.
Rolika. Yeah, so Rolika, when you talked about the surgical excision, did you, the first surgical excision, was there a lamellar sclerectomy done along with
Yes,
the
ma'am.
excision?
Yes,
Okay,
ma'am.
and what did the histopathology show?
Base invasion.
Base invasion. Oh, and you did the primary plaque brachytherapy is what I understood. So I wanted
Yes.
to understand the what led to that. The rotating plaque you did was like, how did you decide on the positioning of the plaque? Was it based on a map biopsy report?
No, ma'am. So we decide the rotations based on the extent of the tumor. So if at all the plaque size is around 20, so it can only cover 20 mm and 20 minus 4 because you want to make sure that 4 mm margin that we keep aside. So if it is covering only 20 mm area, so we decide the rotations based on the diffuse lesion. So as you can see over here, the lesion was extending nearly around 3 quadrants. So we had to
Yeah,
radiate
but
in
she
that
talked
entire area.
about multifocality. So that's why I'm asking this question. The primary tumor, I understand that was
Yeah,
very
yeah.
big to cover.
Yes,
But she
ma'am.
also talked about multifocality. So did we do a map biopsy to understand the multifocality?
No, ma'am, we don't do a map biopsy specifically. We basically excise that lesion. When she said multifocality, they were kind of multifocal, but they were merging into each other as well. So it was like a huge diffuse lesion with multifocal areas. So the rotations were decided on that basis. We
So
took it.
clinically,
Yeah, yeah,
wherever you
clinical
felt the tumor is
analysis.
there. Okay, okay.
GG, yeah.
And
We did not
the
do any specific map biopsy for that. In this case, map biopsy is rather not conclusive.
okay. So map biopsy might be a good idea, Rolika, because many a times clinically we don't a study from our center has shown for both for SDC and OSSN, Like we always if we just go by the clinical parameters for multifocality, we might miss 10% of patients. So it might be a good idea to do a 17-site map biopsy and look into the multifocality. Just a second check.
Right,
The
ma'am.
third thing I wanted to talk about was a very important thing, like the patient underwent cataract surgery. So what was the tumor quiescence duration before the surgery?
Sure. Viparnas, you want to answer? You want me to continue?
Ma'am, I missed the
No.
conversation in between, so I think.
Ma'am's current question. You would like
I'm
to take
asking
that?
the time interval between resolution of the tumor and the cataract surgery, because that is something very important.
Okay, so it was almost 1 year, ma'am.
Okay,
After
yeah.
third plaque.
Okay, okay. I
After
think that
the
is also
final
something the
reference and
audience needs to understand, that we always keep at least,
so
there is no consensus in literature, but at least majority of the centers, we keep a 6 months gap between the questions of the disease and the cataract surgery, because there are multiple case reports which show that if we operate early, there are chances of increased recurrence.
Yes, ma'am. Thank you for highlighting that point, ma'am. The final recurrence, and then only after 8 months from that, the patient had developed neovascular glaucoma, and after that, only after like almost 3 to 4 months. So totally, there was a gap of 1 year to 1 year 2 months between the tumor control and the cataract surgery, because this is another strict oncological principle that is actually followed in ocular, OSSN management.
Yes. Thank you, Farnaz and Rolika, for that exemplary management of a very complex case.
Thank you, ma'am. And ma'am, may I add
Thank
one
you, ma'am.
point,
Thank
ma'am? As you mentioned that you prefer doing map biopsy for OSSN and SGCA, just to highlight that Dr. Shields also follows the same protocol, that she does OSSN and SGCA, both map biopsy till we get a negative. But at the same time with SGCA, it's kind of easy to take the maps, but with OSSN, which are treated with plaque brachytherapy, it's actually very difficult to take the maps because there is no tissue available around. So even if we take, there will be like some probably 5 to 6 foci available, and that causes more post-operative surface damage. So that means there will be more symblepharon formation because it's a radiated area. So that is why Dr. Honavar prefers not to do those in the post-radiated eyes.
Yes,
So
completely agree, Rolika. So
yes.
SGCs, while we do for all cases in our
Yes.
center, OSSN, we only do for cases where multifocality is clinically suspected.
Right, okay. Nice to know, ma'am. Thank you.
Thank you, everyone. And I would now request Ayushi to go ahead with an important announcement. And I request everyone to stay for our customary picture at the end too.
Thank you, everyone, and thank you, Juhi. So every episode, we announce the winners of the previous session. So we had an excellent session on Orbit in September, and I would now request Dr. Nupur, who's currently a consultant at Eye Care, to kindly announce the winners. She's also the core member of the OC Oculoplasty focus group and the team lead for the socio-cultural team. Over to you, Dr. Nupur.
Hi, Dr. Ayushi. Am I audible?
Yes.
Yeah, so very good evening, everyone. Thank you, Ayushi, for the honor, and the heartiest congratulations to the team ExPresYO, which has been so well led by Ayushi for conducting these sessions, which have been wonderful. And greetings to all the panelists and all the mentors and all the participants today. I happened to catch the episode, and I think it was absolutely fantastic. So without further much ado, let me announce the results. So first runner-up is Dr. Yamini Maniktala, who presented a wonderful case on multimodal management in thyroid eye disease. She's from LVPI Hyderabad and was mentored by Dr. Suthi RS from Kerala and Dr. Tarjini Dave from LVPI. So these are the winners of the previous episode of the Orbit ExPresYO session. And the winners is Dr. Aishwarya Patil from Comtus Eye Hospital, Kozhikode, and was mentored by Dr. Andri Chandran, who also recently won the first runner-up Miss Kerala. So she presented an excellent case of myositis that turned out to be an orbital lymphoma. So congratulations to all the winners. And yeah, so that's it. Yeah. So also I would like to, announce and introduce you to the Yossi IROC Season 2. So this is an resident ophthalmic combative knowledge. So last season we had a wonderful participation, pan-India participation of more than 100 residents. So we have online sessions followed by the grand finale in the annual Rocky Call. This time the IROC session has gone international. So all the residents will be competing globally. The registrations are now open, and if you wish to register your residents, you wish to register as team of three, you can contact me or either Ayush or any of the YOSI members who are present here. And we look forward to this, and we had a successful season 1, and season 2 I'm sure is going to be a super hit again. Thank you, Ayushi, for letting us announce this at this platform. Over to you, Doctor. Thank you, sir.
Thank you so much, Dr. Nupur. We couldn't have done this without you, of course. And with this, I would now request Dr. Nilesh, who's the Secretary of the Young Ophthalmologist Society of India, to give his comments.
Thank you, IOC. It has been wonderful. I was there throughout the episode, and this is the only area in ophthalmology that actually I have no clue about. So it is a great learning opportunity for me. I am here as a mentee sort of thing, and most of the things I could because I know the mentors personally, so I could see the treatment protocol and everything the mentors reflection in the mentees presentation, and that is a good thing that the knowledge is being imparted in a very good way to them. And I would like to commend judges also to do a microscopic examination of actually all the presentations and bring out finer points, because we generally do not see that very often in any of the webinars where judges often skip through and just congratulate rather than being very strict. So it was very heartening to see that happening. That elevates actually the academic status of young ophthalmologists like us. So thank you everyone for that, and great going team ExPresYO under Dr. Ayushi's guidance. And looking forward to more, and looking forward to IROC International. I would also like everyone to please circulate this among your institutes so that we have maximum participation as possible. Thank you.
Thank you so much, sir, for your support. I would now hand over the session to Dr. Shruti for her concluding comments, and then we'll take our customary OC picture.
Yeah. Hi, am I audible?
Yes.
Yeah, so thank you so much everyone for joining us. We have actually come to the last and final session of our ExPresYO, which was the creative concept and the brainchild of Dr. Ayushi. She suggested guided grace presentation. This was basically conceptualized to encourage structured case presentation by residents and by fellows of Oculoplasty. And to have meaningful, expert guidance, and to create a supportive learning environment for young ophthalmologists, because usually oculoplasty is not a field which is deeply dealt with in most of the, centers. So with this, I would like to thank our judges, Dr. Lakshmi Mahesh Madam, Dr. Ruchi Goyal Madam, and Dr. Anasua Kapoor for generously sharing a prime time on a Sunday evening. Thank you all the judges for your insightful guidance from your experience. I thank the mentors of today's session, Dr. Sahil Agarwal, Dr. Rolika Bansal, and Dr. Gaurav Patil for their presence. And I'm sure they would have spent a few, sleepless nights before trying to guide their mentees. Last but not the least, I would like to thank all the presenters of today's session, Dr. Megha, Dr. Shravani, Dr. Shumaila, and Dr. Farnaz for a well-prepared and for engaging sessions and their presentations. I would like to thank Numerotech for helping us broadcast and help us without any glitches in this session. I thank the OC Governing Council, especially Dr. Nilesh, for his relentless and for his continuous support for this. I thank the OC Oculoplasty Focus Core Group, which includes our team lead, Dr. Puneet Jain, Dr. Nupur, who has always supported us, Dr. Rituja, Dr. Ayushi, Dr. Rolika for being a part of this. And last but not the least, I would like to thank my co-moderator and a wonderful friend, Dr. Juhi, for this session. I think we'll officially conclude this session. Over to you, Ayushi.
Yeah, I would now request everyone to switch on their videos. Lakshmi, yes, Dr. Shravani, Dr. Shumaila, Dr. Subiksha, Dr. Aishwarya, Congratulations. Dr. Aditi, can you please switch on your videos? Okay, so we'll make this yo sign and then I'll take a picture. Dr. Farnaz. Okay. It's done. Thank you so much. And if anyone has any comments, we would love to have that.
Thank you all. Thank you very much.
Thank you,
It's
ma'am.
really wonderful. All
Thank you so much.
presentations were very good. It's just 1 mark difference in each of them. Difficult to judge such presentations.
Thank
But
you, ma'am.
really good. And
Thank you for
very
all the
important
pointers.
points were highlighted. That's very important. I think this case presentation is a wonderful idea and you learn so much.
Yes.
We
More
learned
than
so
I
much
think
from all of you.
imparting what little we know, learning is more. Thank you.
Thank you so much. Thank you, Ruchi ma'am. Thank you, Dr. Anuswa. Thank you, ma'am.
Thank you. Thank you. Great cases, superbly managed, great moderation. All of you are doing a great job. Keep it up. Thank you.
Thank you.
Good night.
Good night.